So this is me. My name is Hannah, and I am an Operating Department Practitioner, or an ODP as we are more commonly known. But if you have never heard of us, I won't be surprised because not a lot of people have heard of us. So I work at the Princess Alexandra Hospital NHS Trust, and I specifically work in theatres. We have around 11 or 12 theatres here, and we cover main theatres, a day unit theatres, and maternity theatres. So for this case study, we have a 70-year-old male patient with no known drug allergies who has recently been diagnosed with bowel cancer. And he has been scheduled on the emergency list for a laparotomy procedure. Now, in my theatre department, we have 7 theatres up here in main theatre, and one of them is a 24/7 emergency theatre. It can be from people who have come in through A&E, or for patients that are already on the wards that an emergency has come arise, and actually this needs to be done sooner. They can't wait to be put on an elective list that is a planned list where people have waited for a long time. So the patient was brought in by ambulance yesterday to A&E with symptoms for 3 days of abdominal pain, nausea, vomiting, constipation, and no intake of food, but is managing to drink water. The patient was investigated in A&E and was diagnosed with a bowel obstruction. So the bowel cancer that he has recently been diagnosed with, he has a tumour which is causing a blockage in his bowel, so nothing is able to pass through. So subsequently, he was then booked for theatre on the emergency list, and the emergency theatre operates by the amount of cases that are booked and the severity of the cases that have been booked, and they work on a priority basis of quite a few things. So they'll look at how sick the patient is, or how sick all the patients are, and they'll kind of look at who has the more emergency, like the higher the emergency, then and the sicker they are, they'll be put first on the list to be operated on that day, and we'll go by a priority basis. So a bowel obstruction can be fatal if it's left untreated, and it can cause, unfortunately, a patient to pass away. So this patient would class as quite a high priority on the emergency list. So the treatment for a bowel obstruction for this gentleman would be a laparotomy procedure, which is used to fix a bowel obstruction. This is a major procedure because the patient is going to have a very large incision right from their chest all the way down to the groin area. And obviously we're going to be operating on all of his bowels and everything. It's going to be quite a lengthy major procedure, very invasive. So I've done this as if this was me working, because like I said, ODPs can work in the 3 areas, and I work both on anaesthetics and scrub. So I've done this as if this was my day in the life. So if I was on the anaesthetic side looking after this patient, now the more complex the procedure, the more support the patient is going to need from us anaesthetically. So he will need an endotracheal tube, which will go past the trachea in the patient's throat, and we will use that to ventilate him throughout his procedure. He will need an arterial line, which is similar to a blood pressure that goes on their arm, but it's a lot more invasive. So it is a line that will sit inside, usually in the wrist on the radial artery, and the line will sit inside the artery to monitor their blood pressure. They will also have a central line, which is commonly in the jugular vein in the neck, that gives us direct access to the heart for the vein, so pumping drugs through. It will take a lot less time, because if it was the vein in the hand, it would have to go around the whole body to get to the heart, whereas this is situated very close. We will also need to temperature monitor this patient. We will need to monitor the fluids that are going in and out of this patient. So any IVs that we give him, any fluids that we give him, and then any bloods that we give him if he needs bloods. And then coming out, we will monitor him with a catheter and obviously blood loss and things like that throughout the procedure. He will need cardiac monitoring, and also we would have to take into consideration post-op pain relief and management, because he's had a really big incision. He's had all of his insides messed around with. So when he wakes up, his pain is going to be quite high. So we will have to think about things we can put in place for him that will help with his pain relief. Now, if I'm on the scrub side and I'm scrubbing for this procedure, again, the more complex the procedure, the more instruments and the more sets we're going to need for it. So as the scrub person, I will have maybe one of our larger sets that can have like 100+ instruments on it. We will need a lot of swabs and a lot of sharps, more than what you would for a smaller procedure. And then I have to be in control of everything. I have to know where everything is at all times, which can be quite challenging. And also, the bigger the procedure, sometimes the more surgeons there are to work with, because you can have a consultant surgeon who will be scrubbed, and he will have a junior and a registrar, and sometimes even a medical student as well. So there will be a lot of people doing this surgery that will all need things from me. So I have to be quite on the ball with my job of who I'm giving what instruments to. Now, the patient's journey through theatres, they will meet a lot of people from a lot of different professions. So, for example, if we start from the patient's journey in A&E, he will have met the consultant surgeon down in A&E, because he would have assessed him and diagnosed him and said, this is your treatment plan, I'm going to be operating on you. And then if he had any resident doctors with him, they would have met him at that time as well. And then when we get the booking form and we're ready to send for this patient, we send our porters to go and collect them from A&E, that will then pick him up, put him on a trolley, and then they will bring him to us in theatre. So that's when they would meet the porters. And then when they arrive to theatre, they would meet the ODP. We'd greet them, we'd check them in, check all of their details. And that is when they will meet the anaesthetist as well, and when we put them off to sleep. And then the theatre nurses, the HCAs, all part of theatre, they'll meet the patient on their journey there as well. And then when they're awake in recovery after the procedure, they'll meet recovery nurses, pain nurses, physiotherapists, medical students. The list can go on, but that was just everything that came to my head when I was doing this presentation. Multidisciplinary working is a fundamental part of the NHS, especially working in theatres. You need to know and have the skills to be able to work as part of a team. And it is, I'd say, one of the most essential skills, along with communication, otherwise the system just doesn't work. And as an ODP, you also need to know how to work on your own, but as part of a team as well. So our gentleman for the laparotomy, it was a 4-hour procedure in the end, and the team was successful in removing the tumour that was blocking his bowel. And the outcome was that the patient was given a stoma bag. So what happened was, where the patient had the tumour in the bowel, we ended up having to remove, I'd say, a big portion of his large bowel. So, and in order to do that, we had to then give him a stoma bag where the bowel is attached to the skin on the tummy, and then that is when all the feces will come out from, and he has a bag on there to collect all of that. So the patient was stable throughout the procedure, everything went well, and afterwards he would need a higher level of care than the ward can offer, so he got transferred to the higher dependency unit and is recovering well.